Kyle Mounts and myself will be speaking today, taking you through a brief agenda. Our goal is to have you be able to ask as many questions as you have about the beta project. On the next slide, you will see a very brief agenda. We'll begin with welcome and introductions and the purpose. We'll go through some of the survey results. Thank you to all of you who completed the surveys. We will review the measures just very briefly, so there was some confusion about what they were, and we'll have discussion and we'll talk about a future meeting. So let me begin with who else is on the line. So we have on the line, I'm going to say the names. They're in alphabetical order by first name. So if you're on the line and you have not, if you don't show up on our list of attendees, would you please send me an email to let me know that you're actually on the webinar. So we have Beth Martinka, Bonnie Tudebird, Christina Greeton, Claire Reed, Dee Talon, Dory Christensen, Erin McCardle, Jennifer Conrad, Kathy Freege, Nancy Patrick, Rebecca Eberhardt, and Sue Gordon. Welcome, everybody. And as I said previously, if you want to ask a question, use the icon next to your name that says, that is the icon of a hand. Just click on that, and then we will call on you. I see that Stacy Carson also joined us. So welcome, everybody. So the survey, we asked a number of questions. We asked you to go through a SWOT analysis, and we asked you to look at the strengths, weaknesses, and opportunities and threats that you saw in your particular environment. We asked you to can you go to the next slide, Kyle? We asked you to review the Pdsa Cycle to figure out what the best opportunities might be for your organization. We asked you to look at your baseline data, what your intervention will be, and how will you measure success. So briefly, I would like to summarize what people said about the SWOT analysis. And everybody used a little different way of responding, so I will do the best that I can in interpreting answers. So in terms of opportunities, it's the hypertension categories and the appropriate treatments. Another response was in terms of weakness is inconsistency in interpreting the newer guidelines. An opportunity was education of staff and providers. A challenge was the volume of providers and staff and how you communicate change to everybody. An opportunity was to keep patients 72 hours post-delivery. A threat was that physicians may not believe that all patients need discharge education about the signs and symptoms of preeclampsia. And again, inconsistencies in discharge planning and education. So there was a variety, but there are some themes in terms of the guidelines, the education, communicating with different constituencies, whether it be providers, patients, nursing staff. So we got some good information about what you were thinking. The next thing that we asked you about was a Pdsa cycle. And what you told us was that you would implement some new protocols and monitor rates of readmission. You would identify areas most in need of improvement. Some people were right at the beginning of the process of thinking about what needs to be improved, how to look at baseline data, and others were already starting some projects. So there's quite a variation. Start with chart reviews to identify gaps, determine how big of an issue we have and which things will be the quickest and easiest to correct, which is a great strategy. and then decrease the time and increase consistency in treatment plans for patients with hypertension during pregnancy and postpartum. In terms of what intervention you told us you thought you would choose, you said use the hypertension treatment order set. You told us education of nurses and providers about the current recommendations, and then to develop processes to monitor patients and document that follow-through had improved. You would provide patients with tear-off sheets from the Preeclampsia Foundation to standardize discharge education, and you would educate nurses that all patients need instruction on the signs and symptoms. Another person said they weren't sure what their intervention would be, and another one said that they would increase the frequency of blood pressure measurement. Kyle, do you want to refresh us on the screenshot that you have?
Yes, and thank you, Ann. The slide that you see before you right now has a list of the materials from the change package from the Regional Forum series that are now on our website. So this is not a live website picture, but if you were to go to the website, you can do so by going to this address. So it's on the WAPC perinatalweb.org website, major initiatives on the top banner. Scroll all the way to the bottom to WisPQC, and then under resources, you'll see this list. And you can click on any of these materials and have access to these for your own workplace. And we encourage you to take a look at them, see what's there. If you have suggestions of other materials that you think might be helpful or beneficial to other people who are working on improving outcomes, please let us know.
Thank you, Kyle. Then the last question we asked you on the survey was, how will you measure success? Oh, and this is specifically one of the resources that we have. It's the preeclampsia education sheet, and you can order it by going to their website. And all of you who were a part of the Regional Forum series saw these sheets during that series. So we asked you how you would measure success, and what we learned was that you thought you would look at length of stay and reduce the number of readmissions. Somebody said they weren't clear what data they would collect. Some said increased length of stay for women who meet criteria. Others said they would measure their success through a chart review. And another said time of diagnosis to treatment and consistency of treatment for hypertension. Briefly, we'd like to go over what the 4 measures are, because there was some confusion in the survey results. Some things about not sure what data is being asked for was one of the comments, and we want you to make the decisions about what you think would improve care most in your organization and how you would measure that. So Kyle will give a little more background about the measures.
Thank you. As a review, you can see the 4 measures on the slide in front of you. The first is the maternal length of stay after delivery. The second is implementation of appropriate provider education. The third, implementation of education for women about early warning signs of preeclampsia. And finally, the NICU admissions. As you recall from last time or from the regional forums, ACOG recommends that women be monitored for hypertension for at least 72 hours prior to discharge, or comparable services could be provided in the home environment. In order to measure this goal, there are 2 ways that it can be done. First of all, if your facility is using peridata.net, there's a report shown on the screen before you that can be generated automatically. Now, it's important that the data be entered appropriately for this, and specifically, we need, or you will need, the infant's date and time of birth and the mother's date and time of discharge. Peridata can then do the calculation to determine whether or not this is greater than 72 hours. And as you can see here in the example, all hypertensive mother's length of stay, 72 or more hours postpartum and 20 more weeks gestation. You can see the results here, 38.61%. Now it's interesting here that there were 52 records with an unknown number of postpartum hours, so that can affect these results significantly. For people who are not using PeriData, we developed a sheet that can be used. We tried to keep this as simple as possible. It looks at the same criteria that are in peridata.net and allows somebody to answer yes or no for the first two questions, which determine whether or not a woman would be included in the denominator. Some additional questions related to the infant's birth and time, date and time of birth, and mom's discharge date and time. And then finally, to determine if the woman should be included in the numerator if she was discharged at greater than or equal to 72 hours after the infant's birth. The second measure looks at implementing provider education, and it's based on several of the recommendations within the guidelines from ACOG. To measure this, we do not have these fields in peridata.net, so we developed this tool which can be used. The first looks at the levels of care, asking about obstetric services and neonatal services, and recognizing that some of you may have completed the criteria or the self-assessment surveys using the 2004 criteria, while others may have already used the 2014 criteria for obstetric levels of care. Similarly, for neonatal levels of care, we have the 2004 criteria and the 2012 criteria, and ask what levels are appropriate. Then there are a series of questions that ask which of these potential materials have you implemented or are you using for provider education. This is an example of many of the things that are there, and there is space if people are using other ones that are not previously listed that they can turn to those. For NICU admissions, again, there are two ways to monitor this. The first is using peridata.net, and you can see that this is calculated automatically looking at the number of infants admitted to the NICU who had a maternal history of pre-pregnancy, gestational hypertension, eclampsia, or HELLP syndrome. And for people who are not using peridata.net, this even simpler tool has been developed to assist with that. It asks two questions to determine whether or not the infant meets criteria, greater than or equal to 20 weeks, and whether or not mom had pre-existing hypertension or the other hypertensive disorders. These will determine if the infant is included in the denominator. Then if the infant was admitted to the NICU or transferred to a facility to receive a higher level of care, that puts the infant included into the numerator. Finally, consumer education, which was one of the big areas people were interested in the regional forum series. And this is the sheet that we developed for that. We are asking people to survey at most 20 charts each month. If a facility has 18 deliveries in a month, could probably do all of those. If a facility has 300 or 400 deliveries a month, we're just asking for 20, and we believe that there will be a significant enough difference in these to be able to document this change. The top line looks at the total number of discharges for women who are greater than 20 weeks and who are discharged, as you can see. There's spaces for 20 mom charts with yes or no answers. Were discharge instructions given that included information on signs and symptoms of preeclampsia? If they count yeses, they are going to be made up. That's what constitutes the numerator, and the total number down here, 1 through 20, becomes the denominator. There are sampling methods that are available, and we can go over those and talk to you more about that if you would like.
Thank you, Kyle. I'm not seeing any questions yet, but what I would like to do is, Kyle and I had the opportunity to talk with a couple people in the last week or so, and we thought it would be very interesting if a couple of those people would share their stories so far as to what they're doing in terms of improving care for women, pregnant women with hypertension, pregnant and postpartum women. So if you don't mind, Nancy Patrick, would you mind telling us about your project? Kyle will unmute you.
Okay, Nancy, I've unmuted you.
Are you there?
Yes.
Yeah.
Okay. So I'm sorry, I didn't hear what you said because I was trying to pick up the phone.
Oh, we had the opportunity to talk with you about your project and asked you if you would mind just describing it to the rest of the group. Some people may have a very clear idea of what they're going to do starting January 1st, and other people might still be trying to figure things out. So I thought it would be useful if we had at least 3 vignettes or case studies about what people are doing. And just to give you a little advance, we are very interested in hearing from Claire Reed as well. Claire is a family physician at a federally qualified healthcare center, so she represents the ambulatory part of care. And somebody else who has a pretty well-developed project right now, and Kathy Friege, don't be surprised, but if you would mind sharing your hypertension plans with the group as well. But first, Nancy. And,
Sure.
and Nancy, I didn't give any introduction as to who you are, so please.
Okay. My title is Advanced Clinical Registered Nurse at St. Mary's. I'm new to the position. I'm working with the clinical nurse specialist group here, but my education isn't as a clinical nurse specialist, so that's my title of Advanced Clinical Nurse Registered Nurse. How we got started in this, we had a root cause analysis on a poor outcome with a hypertensive patient, and we looked at all the different ways that we thought we could improve our care. So it kind of came before I know about the WABC project, but it's really coordinating well. So what we've done is we looked at the ACOG Committee Opinion 623 that came out in February on emergent therapy for severe hypertension, and we took that along with our medical staff and created an EPIC order set based specifically on the guidelines from that. And then for data, we have been collecting data prior to initiating this order set of women who meet the criteria of 160 or 110, for more than 15 minutes, like in a hypertensive crisis, from the time that they were diagnosed with that till the time that they receive treatment. And then we've collected, or we're in the process of collecting that data, and now we've initiated this order set, and we want to see if we have improvement in time from diagnosis to treatment after initiating that. So that's kind of the gist of the project.
So it had started, your project started previously because of a poor outcome, and you started looking at what went wrong, or what could have been done better.
Right.
Okay. So that gives people some things to think about as to how to identify the greatest need. Kathy Friege, would you mind? First of all, I should ask, does anybody have any questions for Nancy? I'm not seeing. Oops, okay. Yes, I do. I see okay. Bonnie has a question.
I will unmute you. Okay, Bonnie.
Hi, Bonnie Tudeberg, are you there?
Yes, it is. I'm here. Thank you.
Okay, great.
Myself. My question was, how did you find the blood pressure values? Did you do retrospective review on all of the EPIC charts on a certain population of patients, or were you able to create an EPIC report for that?
It was through EPIC, but yes, we had to gather all of the data. It's been quite a process. I have a nurse champion that's been working on this. We have what's called an Emerging Leaders program, and she started out with this and has continued with it. So she's helping to collect that data.
So she's doing individual chart review to find those values.
Yes, she had some criteria to limit, what she was looking at, and then she's going through those individual charts.
Okay, very good. Thank you.
Thank you, Bonnie. I don't see any other questions. Do you, Kyle?
No, I don't, and I don't see any that have been entered in manually. So
okay.
I will unmute Kathy Frege then.
Thank you. Kathy, are you there? Kathy, are you there? We can't hear you. Oh, there you are.
Can you hear me?
Now
Okay.
we can hear you. Great. I didn't want to put you on the spot, Kathy, but you have a pretty well-developed idea, and I thought it would be very useful if you shared it. So if you're willing to do that.
Well, we're a little bit on a continuum. We've identified that we needed to address the hypertension population because we've been seeing more readmissions for women for management of hypertension or preeclampsia. So we had a OB summit last year where we started working on this, but nothing real formalized. One thing that we did develop is a clinical guideline on the management of the obstetrical patient with acute onset severe hypertension that kind of took its information from that ACOG committee opinion. So, so we identified women with severe hypertension and how we should manage them, but we really haven't addressed the other hypertension populations, and that's, I think, what we're going to focus on now. And we've identified a group of nurses who is going to make this their clinical project. We usually have a clinical project every year looking at the measures you identified. And the one that we're going to start with that seems pretty easy and straightforward is just to make sure that all women will be discharged receiving instruction on signs and symptoms of preeclampsia. So we use HealthWise through Epic, which is patient instructions, and in addition we're going to give them that tear-off sheet from the Preeclampsia Foundation. So a lot of this is in discussion right now. We really haven't come up with a lot of specifics. We know that some of it will be through Pdsa, some of it will be through manual chart review. But we also have a multidisciplinary team, and we have met twice. And there's a lot of good engagement from our provider staff as well of how we want to manage these patients. And we have a current MFM who just came from Seattle whose training has been on hypertension. So we're looking forward to her sharing how they manage these patients out there, and developing a hypertension policy that will give our staff and providers more direction so we can be on the same page for early identification, treatment, and management.
Thank you, Kathy. I think what's interesting about both of what we've heard from Nancy Patrick at St. Mary's in Madison and Kathy Frege is that they have had some prior history looking at hypertension and the treatment and care of women and the consequences, so that they've had a bit of a head start. I'm wondering about the rest of you and what you're thinking as to how, when January 1st comes around, you're going to be implementing this beta project. Before I ask for some feedback from the rest of you, I'd like to have Claire Reed talk about some of her plans. And Claire is in a little different clinical situation and has some different ideas, but we're so pleased that she's someone who represents outpatient care and not just the in-hospital treatment of preeclampsia. Claire, go ahead.
Thank you, Anne. So I think the plan for us is to hopefully start making sure our patients are better educated about what to look for. We have a very significant Hmong population. Many of them are grand multips. We don't have a lot of educational material for them, and I'm really hoping to use the little pictogram handout, hopefully with them and our Spanish-speaking patients, because it has that in Spanish on the back. And then maybe do some assessment of how we approach our education and what their recollection of learning the important signs and symptoms of preeclampsia is. So we think we do a pretty good job, as do most of us, but whether patients hear that and recall that, I think is probably, for all of us, a big challenge. So finding out if using this as a tool can help patients, having it, maybe we're thinking of blowing it up, or at least having it in the rooms when they come in for their OB visit, so visually they're seeing it again, as well as hearing it from us as a reminder. We do OB, but our deliveries are handled by a residency program in town, and implementing change at the hospital level is out of my control right at this point. So we're hoping to affect the outpatient clinic assessment of blood pressure and preeclampsia, rather than either give up the project for good or think that we can really impact the hospital part of it.
Claire, do you see the babies and the mothers postpartum, and if so, when?
We do. We typically see them within the first week of discharge, and the benefit, at least for me, from a family practice standpoint, is I see the family. So often the dad will come, but definitely mom with the baby. 1 week, we do a 2-week baby check, and then start in on the 1 month, 2 month, 4 month baby checks. We always ask moms the postnatal depression questions when they bring the baby in. We haven't typically at the 1 and 2 week done blood pressures, but we are planning a change in our process to look for that. I think that, again, with family practice, we have a unique opportunity to make sure we're addressing the whole family, so not just doing the well baby exam, but making sure we're intervening appropriately for moms.
And you have some really unique opportunities in terms of focusing on the prenatal care and what kind of education you can do during that time, and then the immediate postpartum follow-up. It's really a perfect situation.
You know, I think historically we might be able to look back at charts. Certainly we get the reports of the hospital stay, and so we can contribute, you know, data if we have that available, but not maybe impact it directly in the hospital setting.
Okay. Does anybody have any questions for Claire?
I'm interested if there's anybody else out in the audience right now who might have a similar kind of clinical setting, not primarily based in the hospital. Is there anybody who's listening who would be able to comment on anything they've heard that might be helpful for them? You can just raise your hand. Okay.
I'm not seeing any hands raised, but I do see that one of our participants is from a county health department. Julie, would you have any comment? If so, just raise your hand and then we'll unmute you. Okay, I'm going to read that as no for now. I think now it's time to, oops, Jennifer has her hand raised. Jennifer Conrad. Go ahead, Jennifer.
So I was just wondering, and maybe I missed this from the first call, is there going to be a list of the participating hospitals within the project. So if we have questions, like I heard Nancy Patrick talk about her EPIC order sets, we also have EPIC, and it, you know, at this time we weren't really going to implement possibly a new order set, but I'd be interested in seeing what they have, you know, so as this work gets going, we could look at that.
I think that when January 1st comes and we know exactly who's going to be part of the project, we can definitely share email contacts with all the group hospitals or organizations in the project. Until then, Nancy and Jen, are both of you in agreement that I could connect the two of you? I can email one with the other's email address. Would that work?
That works for me.
Okay.
Okay.
That works for me as well.
Okay.
This is Nancy.
Okay. I will connect the two of you to share that information.
Perfect.
Thank you. Any other questions so far? Okay, so one of the main goals for this conference or webinar today was to make sure that you all were as comfortable as you possibly could be with starting the project on January 1st. So what I'm interested in knowing from you all is, if you don't have a very well-developed project in mind right now, do you have a clear idea of what needs to be done to get to be able to do a project in the first 4 months of 2016? Does anybody have any reaction to that? I don't want to just randomly pick on people. I'm not seeing any hands raised.
And if you want to, if you don't want to speak, there's a question panel that you can type your question into, and then I can relay that to Ann in the audience for discussion.
Thank you, Kyle. That's a good point. I guess one of my major questions is, can we assume that everybody who is on the call will be part of the beta project? That's one of the important things that we need to know. If you intend to be on the beta, be part of the beta project, could you raise your hand? We won't, that'll just be a way of taking a poll, but we won't necessarily call on you. Okay. Excellent. So let's see. Kathy Friege, I don't see your hand up, but it seems like you're going to be, now I do.
Okay. Wow.
You're hesitant. Okay, so let me just do a quick tally.
Looks
1,
like
2,
9.
3, 4. Okay.
Yes. Okay, good.
Excellent. Is there a way, Kyle, that you can record this?
Yes, I can.
Okay. Okay. Wonderful. So we basically can start our email list before January 1st. If it's okay with all of you who have raised your hands, I can share your email contacts with the rest of the group. So if you want to talk with each other, problem solve, you can do that. If there is anybody who does not want me to do that, please send me an email immediately after this call. And my email is conway@perinatalweb.org. And I think we'll have our email addresses at the end of the slides.
Yes. It looks like we have two questions that people typed in. The first one asks about how to gauge provider education. Is it only reflected in the orders, protocols in place? I could go ahead and start with that, and feel free to interject any comments that you may have. At this point, that's what we're looking at, the implementation of things like protocols, guidelines, management strategies, algorithms, because we haven't gotten to the point yet where we can get in and actually assess provider knowledge on those things and actually evaluating provider practice. And so we're looking at the availability of those materials that we believe are going to be associated with better informed providers and perhaps more appropriate and consistent care for women with hypertension. At some point, it would be nice, and we are one of the groups that's working with us in the Quality Collaborative is the Wisconsin Medical Society. And they have a vested interest, of course, in provider education as part of the maintenance of certification program. So that's one of the things that we will be at least looking at in the near future to see how those things might be able to be incorporated.
One of the things that we did at the Regional Forum Series was we did a pre and a post test. And I'm thinking if you wanted to focus on provider education, one of the things that you could do is identify groups of providers, you know, whether you work with family practice physicians or OBs or whoever, identify the providers, the nurse midwives, whoever, plan for some educational sessions, do a pre-test, provide the education, and do a post-test to demonstrate a difference. Now that's not going to demonstrate a change in practice, but it will demonstrate a change in knowledge. And we were very surprised at what we learned from the regional forums by doing that. Kyle, do you have anything you want to add to that?
No, I think that summarized that information very well. Does that answer your question? You can just type a response and I'll pass that on. I think that one of the things that would, thank you, yes, the answer is yes. One of the things that might help that particular part of it, the provider education advance forward, is if there are physicians who are truly invested in the process also. So if somebody like that's available, working it into like a grand rounds or some other continuing education kind of format could provide an opportunity to assess, at least educate, knowledge changes better. And Jen Conrad has her hand up. Jen, I've unmuted you.
Thanks, Kyle. For those things that we're submitting manually or doing manual abstraction, like the patient education part, what's the process for me to submit that then so it's included? I think I missed that.
Actually, that's a process that we're still defining. Would that be fair to say, Anne?
I think that would be very fair to say. And some of the things that we were we're making decisions about in the next couple of weeks is whether there will be a website that you can enter the data into, or if somehow we're going to be getting papers from you. We would prefer not to do that. And we would just want summary information. We don't want any identified information to be shared. So we're going to be making those decisions in the next few weeks. So that's a good question.
Thank you.
You're welcome. And there was another question you said, Kyle?
Actually, the other one was a comment. The participant indicated that she and her staff will be starting with education, staff, providers, and consumers, and the measurements in January.
Excellent. Oh my gosh. Does that person want to comment on that?
Bonnie, would you like to comment? Just raise your hand if you do, and I'll unmute you. Okay, Bonnie, you're on the air.
Yeah. Oh, thanks. So I think what we think we're going to do in January is, because we've got some nurses that are doing professional practice development, we're going to enroll them in to do something like everybody will go through a retraining on proper blood pressure taking first, and then what do the values mean and why are they important? So we'll have a nurse really train each other, and then she'll gain points or whatever for our system, for her professional development packet. And then we'll go to the provider meeting and talk about rolling out the practice management model, the algorithm. I think we're going to institute that. And then we're going to use the resources already available for consumer education and roll that into a part of the discharge education checklist and make sure that's provided. We'll use a smart note and Epic to indicate that it was given. So that's how we'll be able to measure it. So I think basically all the tools are here. We just have to put them all together and measure it.
That sounds like a very comprehensive educational approach. Will you be, Bonnie, will you be using the Perry data report to keep an eye on length of stay and NICU admissions as well?
Yeah, those are the two tools I would use. Right now, I'm not clear that everybody records the time of discharge on the log sheet, so we'll have to make sure that's being done well. But I can also use Epic for that if I have to backtrack on that one. And then the other thing is, just an FYI, in a different tool that we were measuring for a different collaborative that we're in, NICUs are defined differently all over the place. So I'm assuming in this measurement, we're going to call an NICU any higher level of care than what they are in now.
I would defer to Kyle on that one.
Because sometimes NICUs are level 2 special care nurseries or inside the nursery, but it's a different level of care. And so when we were doing transfer to NICU as a different measuring tool, the answers were all over the board because people define NICU differently. And we were working with some hospitals in different states.
I can appreciate the challenges that you're having with that, and I think that as long as you've defined what you mean by that, that's reasonable. I hope personally that sometime in the future we get to the point where all the birth hospitals in Wisconsin have taken advantage of the levels of care self-assessment survey, and then you can specifically talk about level 2, level 3, level 4, as opposed to terms, like you said, that could have ambiguous meanings like NICU and things like that.
Very interesting. Thank you, Bonnie.
Well,
does anybody else have questions or comments? I'm quickly looking through the list. I'm not seeing any. So the next thing on our agenda is to schedule some monthly webinars. We agreed that anyone who is going to be part of the beta project would be invited to monthly webinars. And we want some input as to what's the best time, the best day, the best date in the next 4 months, January, February, March, and April. We thought that there was probably some merit in bouncing around in terms of not making it, say, consistently the third Wednesday of every month, because if someone has a conflict, then they have a conflict all the time. So what I'd be willing, or what I would like to hear, is if there are any dates that would absolutely be best for us to avoid. Of course, we will avoid April 24th through 26th, which is the WAPC annual conference. And we will also avoid the Martin Luther King holiday in January. So if people have any comments, would you please send those to us? You can put those in the comment pane or the question pane, and you can also email us after. We will set the time from 12 to 1, however. We've found that that seems to be the best time for people. Either that or very, very early in the morning, which doesn't seem to be the best time for some, but for others. So we're going to go with noon to 1, and then just let us know if there are days that we absolutely should avoid. I don't have anything else other than on the next slide there is our contact information. If you need to ask questions, if you don't understand some of the measures, whatever, please let Kyle or myself know. In addition, this webinar will be archived on our website. It'll probably take about a week for it to be there, but the December 6th webinar is posted there, and this one will be added as well. I look forward to talking with you in January. We'll let you know the date as soon as we get some feedback from the participants. And best of luck. Happy holidays to all of you. And Kyle, do you have any closing comments?
I will, as a response to a question that just came up, where can we find the webinars? If you go to the WAPC website and go to the Major Initiatives tab at the top, and then scroll down to WisPQ, which is at the very bottom of the list, and then go over to Resources, the webinars will be right there. And if you can't find them at all, we can send the specific address to the page so that you can access those more directly. Another question just came up, will you be providing minutes from this webinar? We hadn't talked about specifically minutes, but we are thinking of generating a list of frequently asked questions to have on the resource page for the WisPQC section. So if that will be helpful, go ahead and let us know. If you've got other specific reasons why you would want minutes, just go ahead and send those to us, and then we could take a look at that and see how we can meet the needs of people who are going to be doing this. And as far as other topics, if you don't have specific questions but just need a good cheer section to help you move forward with this, feel free to call for that too, because we're really excited about this initiative. We're excited about the future of perinatal health in Wisconsin, and we're excited that you want to be part of this.
Well said, Kyle. We are very excited about this, and I am even more excited hearing some of the ideas that you all have shared today. So please keep up the enthusiasm. We'll be sharing the email list, and until the January webinar, have a wonderful holiday and see you then. Talk then, I should say. Bye-bye.